Good morning, Ronald Alperson here. I'm presenting on behalf of Medicine 3, Gut Feeling Gone Wrong. I'm presenting a 36-year-old female employee at shoe manufacturing company from Vellore, presented with complaints of 1 week duration of high-grade continuous fever with chills and rigors and vomiting, 5 to 8 episodes of vomiting per day, mainly postprandial, and loose stools 8 to 10 episodes, watery, small in quantity, associated with severe abdominal pain, mainly in the umbilical, epigastric, and right hypochondrial regions. Personal history of consuming outside food intake 1 week prior to the illness. No other comorbidities, no history of recent travel history. On examination, patient was conscious and oriented, pallor present and icterus present, no cyanosis, clubbing and lymphadenopathy, bilateral pedal edema noted at the time of presentation. Vitals at the time of presentation, pulse rate 140 beats per minute, blood pressure 100 by 60 millimeters of mercury, respiratory 22 per minute, and saturation maintained 95% in room air. Per abdominal examination, abdomen was distended, tenderness in the epigastric, right hypochondric regions, and hepatomegaly present, no splenomegaly. Other systemic exams are unremarkable. And the differentials considers for my patient, she's a 36-year-old lady with acute onset of fever, vomiting, loose stools, and abdominal pain with tender epigastrium and hepatomegaly. I consider differentials of acute cholangitis, infective gastroenteritis, enteric fever, malaria, severe dengue, leptospirosis, scrub typhus with multi-organ dysfunction syndrome. Um, my initial investigation shows hemoglobin of 12.12 gram, platelet counts was 51,000, WBC 6,500, total bilirubin was elevated 5.72, lag bilirubin 5.54, conjugated hyperbilirubinemia, AST and ALT was elevated, alkaline phosphatase was also elevated. Sodium on initial presentation is 124, UER 186 and creat 1.14. Initial investigation shows dengue serology negative, scrub type was also negative, viral salmonella paratyphi IH was positive, urine culture and sensitivity is negative. Ultrasound abdomen initially done shows features of acalculous cholecystitis with hepatosplenomegaly. During watch day, patient continue to have persistent GI symptoms with fever, high spiking fevers even after starting antibiotics. On day 3 of admission, patient developed hematochezia, 3 episodes of hematochezia, and sudden significant drop of hemoglobin from 12 to 3 gram. So further, patient required inotropic support and shifted to MSDU. In view of bleeding, we did gastroscopy, which was only antral erythema. CT abdomen done, which shows features of inflammatory and infectious change in the distal ascending colon and distal ileocecal junction, and moderate hepatosplenomegaly. In doing course of time, blood grown salmonella paratyphi A. CT angiogram later done, it shows active hemorrhage noted in the arterial phases images at the pelvic ileal loop. So coming to my diagnosis, it's an enteric fever, salmonella paratyphi bacteremia, complicated by multi-organ dysfunction syndrome with superior mesenteric artery bleed and acalculous cholecystitis. So Salmonella paratyphi, it's a gram-negative bacterium mainly transmitted by fecal-oral route. It's high prevalent in less developed countries, especially in Asia. Main complaints, patient presented with stepwise fever pattern 95 to 100%, malaise, headache and anorexia, abdominal pain and discomfort, and hepatosplenomegaly, sometimes present with alternating bowel habits, sometimes constipation and diarrhea. Complications of Salmonella paratyphi, gastrointestinal bleeding plays 2 to 10% as a complication, intestinal perforation 1 to 3%, acute hepatitis elevation of AST and ALT 5 to 10%, sometimes present with encephalopathy of 1 to 2%, and acute kidney injury of less than 1%. Rhabdomyolysis present at less than 1%. Endocarditis and myocarditis is very rare condition, present at 1%. Hemophagocytic syndrome also present at less than 1%. So, systemic review of global epidemiology, clinical laboratory profile of enteric fever. This analysis shows the study done in 1962 to 2013. Total 180 reports included in the study. Out of this, 25 studies are from India, included both South Asia, East Asia, Africa, and Europe. Both children and adults were included in the study. shows more common presentation with fever, with hepatomegaly, and most complications of GI bleed is less than 7%. These are the case reported, which mainly suggest patients with Salmonella paratyphi can present as superior mesenteric artery bleed prior with either aneurysms, myocardic aneurysms, or any splenic vein thrombosis, or any multi-organ dysfunction. So our patient we started initially on peptides in view of shock upgraded to meropenem and Sapotica. Blood transfusion was given, inotropic support, fluid and electrolytic management was given. Patient in view of superior mesenteric artery bleed, we did superior mesenteric artery embolization. So patient symptomatically improved. His hemoglobin went up from again 3 to 9.6 later discharge.
Thank you. Sorry, what was the sensitivity pattern of the Salmonella paratyphi?
Span susceptible, sir.
Okay. Questions? Fit for that.
For somebody presenting with fever, gastroenteritis, and hepatomegaly, why was cholangitis your first differential without jaundice?
With jaundice is present from the patient.
It was there in again in the summary. Sure, there's okay, but I think in your summary you mentioned fever, gastrointestinal symptoms, hepatomegaly. So there was no liver abscess, none of those differentials you had included. Is there hepatomegaly in cholangitis?
No, jaundice is present from one presentation. Jaundice is there.
All right. Other thing I wanted to say is your discussion should be a little more focused. If you want to tell us the specific, everybody knows what enteric fever clinical manifestations commonly are. If you're going to tell us about the SMA bleeding, you should specifically focus on that. Otherwise, it's a little difficult to follow. And text was very difficult to read from the back of the classroom, so just make it fine.
Sorry.
Interestingly, what is sonographic Murphy's sign?
On using ultrasound probe, patients
so
having
not
tenderness.
Clinical, but only picked up by ultrasound, is it?
No, it's a clinical.
Okay.
Sorry, day 10 of illness. 1 week history on admission day 7. After admission day 3, patient have sudden drop in hemoglobin from 12.2 to 3, sir.
How long the patient been in hospital?
3 days, sir.
3 days. So on arrival 12.3, on day 3 of hospital stay, patient developed HbF 3.
3, sir.
That was day 10 of illness.
Day 10 of illness, sir.
Operations in typhoid paradigm. Part of the
usually ileocecal junction, ma'am. Where patches is more so.
Supplied by which artery?
Superior mesenteric artery, branch of internal.
I'm asking you, did it target the correct artery? In your mind, is the anatomy clear?